Hello. Hello. Do you listen to me?
Hello, how you doing?
Do you see my camera?
Hold on.
I don't speak English very well. Sim. Mais um mês. Chegou aí. Fala.
Okay, you wanted to check the camera?
Hi, John. Good morning. It's Diego. I'm here
Hey,
now.
hi, Diego. How you doing?
Can you see our image?
I can see the sonar production, but I can't see the camera.
Okay, so let me see what's happening. Just a minute.
You can go to the YouTube link. It'll show you what I see.
Okay, just a minute.
You know what a visitor would see.
Uh-huh. Let me see. Did you select myself as
As a co-host?
yeah.
Yeah, sure.
So I think I'm going log out and log in again. Okay.
Okay, I'll be here.
Sair dessa sala.
Aí eu saio aqui.
Leave, ali embaixo. Leave webinar.
Okay. Okay, there we go.
It was because the option start video wasn't showing for us, wasn't available.
Really?
When we log out and log in again, the
Yeah.
option started to show. So now it's okay. We are just waiting for the professors,
Okay.
and I think I'm going to set up the computer at the surgical room.
Okay, one thing before you go,
Mhm.
yeah, we'll be communicating by WhatsApp, but I had a question, what I want to ask you.
Okay.
Oh yeah, do you have the lineup? Do you have who's speaking today, or should I get that from Marcos?
Yeah, I think I sent to you on Monday. It
No, now, no, I don't need it Monday, I need it now.
let me see. Just
I've gotten various schedules, various times.
Actually, I'm waiting Dr. Marcus to get in
Okay, just
because
send it on when you got it, okay?
yeah, and when as soon as he comes, I will ask him about the schedule for today, the exactly schedule. Then I send to you.
Okay,
I really don't know with that. I
I'll get
he
it from
told,
Marco, I'll get it from Marco.
okay, try to talk to him.
Yeah, do your
See,
thing, I'll get it from Marco.
ok. Tava perguntando em relação à agenda de hoje, se já tem exatamente. Viu? Hi, John.
Yes,
Do you still listen me?
yeah,
Let me tell you. I've heard that we have a procedure to do. Sorry. Sorry. We have a procedure to broadcast that will happen at hemodynamics here at the hospital,
okay,
and I don't have uh, an equipment set there. It was I was just I've heard just now about this, and now I let me see.
what is the schedule for today? What are we doing? Hello, Marcos, could you tell me the schedule, please? What's going on today?
Yeah, I will connect with my smartphone
Okay,
in
just
order to
give me what we're
do
doing.
there.
I need to promote, so I need to know what we're doing, what speakers or what. There's Diego, how you doing?
Let me see. Do you hear me?
Yes,
So I'm gonna use this equipment, this smartphone, in order to broadcast from hemodynamics.
okay. You're gonna use the smartphone as a camera?
Let me see. How can I just need to, yeah, like this.
It'd be nice to have a tripod, huh?
Nice what? Sorry?
It'd be nice if you had a tripod.
Yeah, I'm gonna use a stabilizer, an Osmo.
Yeah, you could use something though. It's a good camera.
So I just wanted to check it if it's okay.
Okay, if ever you want to check it, you can look at the YouTube. That's what I'm seeing.
Good, but it's a good image.
Yeah,
So
you're showing the hallway, right?
yeah, I'm showing
Yeah.
the hallway at the hospital.
Yeah, okay.
So I think the connection is good, and we may proceed like this at the
Okay,
hemodynamics.
just for your own information,
Mhm.
this is the way you have the audience ask questions. You
Mhm.
can walk and give them a smartphone like this, and then they can ask the question with the smartphone
Mm.
and be on the broadcast
Good, interesting.
in the future. I know we don't have a big crowd, but when you do,
Mhm. It's a good idea. It's a good use.
yeah,
So
we
it's
used
okay.
it. Okay, used it in Yemen that way.
Good. So I'm gonna leave the meeting, and when I get there, I log in again. Okay.
Okay, okay.
Hola, John. Can you hear me? Is he there?
Yes, I can hear you. Can you hear me? Hello, can you hear me?
Hello? Can you see me?
I see, not really. I can't, there
the
you go.
camera-
I see you. I see you now.
Is the camera online, Diego? No power, Diego, here?
It's okay now. It's okay. Yes, yes.
Just adapter.
Yes. Okay.
Hello?
Você tá ok, tá online, só falar com ele.
Hi, John. Let's go and begin officially.
Okay. Whenever you're
Hello,
ready.
good afternoon, good morning. John, can you hear me?
Yeah, okay, just 1 second. Let me introduce you, okay?
Hello.
Yeah, can you hear me?
So let's begin officially. Echo. Test for echo. Echo. No echo. Hello. 1, 2, 3. Let's begin the show. Show. Hello.
Try now. My microphone was open.
Hello. Can be there in the United States, the problem. Hello. Okay.
No, somebody has their,
Hello.
somebody has a YouTube open.
Okay, Diego. Okay. John, can we begin now officially? Hello, John.
Yeah, let me introduce you, okay?
Okay. Go.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett up from Miami Beach, televising for Neurosurgical TV. We're starting. We're the second day actually of the Encontro webinar from Brazil, featuring some great speakers. And I'll let Marco take over. Hello, Marco. Welcome.
Yeah, welcome, John. Thank you. And sorry for the delay. It was some local problems here, but now it's okay. And yesterday we were happy because there were the birthday of Professor Shu, and we had done many collaboration with him. We are happy that have the support of ACNS together in the German Society of Neurosurgery together also with us. And today we're glad to have here Professor Jim-Song Wu, well-known neurosurgeons, worldwide known by glioma surgery. So we are really happy and glad to have you here. It's an honor for us to have you here in my town. And I invite Professor Bin-Chu to present Professor Wang. Jin-Song Wu.
Okay. Dear colleagues, Professor Wu Jing-Song is my colleague in Huashan Hospital, and he is very good at glioma cases. And today he's presented his experience on glioma case. Thank you.
Thank you, Professor Marcos Wagner, and thank you, Professor Xu Bing. Thank you for a very kind introduction. And on the slide, you can see the brief introduction of myself. Now I am the chief physician of neurosurgery in Huashan Hospital. And Huashan Hospital is the second largest neurological center in China mainland. And now our hospital is the National Center for Neurological Disease. And today my topic is about the lobectomy for IDH wild type TERT mutant glioblastoma. So this is a topic about the glioma surgery. Glioma surgery is also my concern operation. And totally my personal experience for glioma surgery is above 500 cases. And the total case number in my department is over 3,000 cases of cerebral glioma craniotomy. So first of all, let's make a short review of Dr. Wokdande 100 years before. Dr. Wokdande published a paper about the removed right non-dominant side cerebral hemisphere for certain tumor with some neurological deficits, for example, hemiplegia. The major case for malignant brain tumor is glioma. So 100 years before, Dr. Dandy supposed more extensive resection will be good for our patient with malignant glioma, especially for glioblastoma. Of course, he cannot cure the patient, but actually he prolonged the survival of the cases to more than 2 years. It's a brilliant achievement in his era. Now, the modern neurosurgical technique was suggested for our glioma patient treatment. The standard strategies will be kicked off by the surgery. So by using the craniotomy, we can take off the tumor lesion. We can reduce the tumor cell burden. We can give the specimen for neuropathologist, for molecular, for histological evaluation, as well as molecular evaluation. And after that, the second line is the chemotherapy, radiation therapy, and now the tumor treating field, TTF, is a new standard technique for glioma treatment, especially for malignant glioblastoma. So one multi-center retrospectively study indicated that the supramarginal tumor resection, including both the contrast enhancing lesion as well as non-contrast enhancing lesion resection for the IDH wild type glioblastoma is associated with optimal progression-free survival and overall survival. So you can see if we gross totally resect the contrast enhancement of the lesion as well as 95% non-contrast enhancing tumor components, the survival benefits is obvious. To achieve the goal of maximal safe tumor resection, more and more modern technology will be recommended to our neurosurgeons as well as our patients. For example, the neuronavigation, image-guided surgery, the intraoperative real-time MRI imaging, the intraoperative fluorescence imaging, for example, fluorescent sodium as well as 5-ALA. And we can also use intraoperative ultrasound for some in some small medical center because relative cheap expense for the equipment cost. For safe reason, we can use the intraoperative neurophysiological monitoring. And for some cases, especially for the dominant side cases, we can do the brain mapping under awake anesthesia. So awake craniotomy is critical for dominant side as well as for eloquent area glioma resection. In our hospital, a digital integrated operating theater with high field MRI as the core is established. So this is integrated intraoperative MRI digital surgical suite. The core of the suite theater is the intraoperative high field MRI scan. And we can combine in combination with the multimodal image data sets. And for the functional mapping, we can perform personalized brain mapping, cortical or subcortical mapping to preserve the neurological function of our cases. So this is the routine work of neuro-oncological surgeons to treat the glioma patient. New area. In 2021, WHO classification of CNS tumors has stepped into the new area of molecular pathology. So in the new area of molecular pathology, personalized surgical strategies have been proposed for integrated diagnosis of glioma of different types. For example, for glioblastoma IDH1 type, more extensive resection was recommended. As I mentioned before, not only the contrast enhancement, which will be defined as gross total resection in accordance with renal criteria, but also the non-contrast enhancing tumor lesion resection will be proposed for malignant IDH1 type glioblastoma for survival reason. Intraoperative molecular detection technology has been developed well. It continues to improve, and now we can complete rapid detection of major classification indicators such as IDH, such as TERT promoter within half an hour. So in our lab, we can use ARMS PCR technology to detect the biomarkers of IDH mutant as well as TERT mutant for the glioma cases. The sensitivity and the specificity are all close to 100%. So the surgical strategies based on the intraoperative rapid molecular taping are proposed for clinical use. For example, in this paper published by the USSF group, Dr. Jumper think for younger glioma cases, especially for the younger patient with glioblastoma, maximal safe resection, including not only contrast enhancing component, but also the non-contrast enhancing component on T2 FLAIR image will be recommended for the patients. In conclusion, most studies reported the prognostic advantages of supramarginal contrast enhancing as well as non-contrast enhancing resection over gross total resection in accordance with T1 contrast imaging. However, the definition of supramarginal resection are different. Some researchers have proposed lobectomy again, but only a limited number of studies reported the prognostic significance of lobectomy. Only I browsed the internet, only find the 3 papers on World Neurosurgery, Journal of Neuro-Oncology, as well as Journal of Neurosurgery. So based on the background, I believe it's the time to re-evaluate the implications of lobectomy for IDH1 type malignant glioblastoma. So we retrospectively analysis the previous data of our team and found that the lobectomy has a trend of survival benefits compared with a gross total resection of the contrasting enhancing tumor component. So you can see this is the Kaplan-Meier curve of log rank test. You can see the p-value is 0.1 is close to the threshold. So it indicates the trend of survival benefits. And how about the multivariate analysis? The results of multivariate analysis also suggested that a lobectomy may be an independent survival benefit factor. So here you can see the significance. The p-value is 0.08, close to 0.05. At the same time, some surgeons will worry about the post-operative neurological function. So we compare the neurological status before operation and after operation. We follow up the cases. And you can see here the 1 month, 6 months, 3 months, and 6 months, the KPS scores before surgery and after surgery was equivalent. There is no significant difference was detected. So that means lobectomy does not reduce the patient's quality of life after surgery. Therefore, we suggested that lobectomy based on the anatomical landmarks can be reintroduced for malignant adult diffuse glioma surgery, especially in IDH wild type and third promoter mutant glioblastomas. Of course, for the functional preservation, we will recommend awake craniotomy for dominant side glioblastoma cases, especially for language mapping as well as cognitive function preservation. For example, for this gentleman, we can request him to play violin during awake brain mapping to preserve the English, to preserve the musician function during tumor resection. And also, this is the standard procedure for intraoperative neurophysiological monitoring. We can perform cortical mapping. 1, 2, 3 indicate the language area, the positive side of the language area. And M indicate the mouth movement, H indicate the hand movement, hand notch of motor cortex. S means the sensation of the posterior central lobe. The P indicate the subcortical motor pathway, pyramidal tracts. So for this case, we can resect the tumor until the functional margin posterior, very close to the precentral sulcus. When we talk about surgery, what do we really talk about? I think when we talk about surgery, first of all, we should talk about the anatomy before craniotomy, especially for junior, for young neurosurgeon, for our residents. We should train them, be familiar with the landmark of the cortex. On this image, you should find the Sylvian fissure, the anterior Sylvian fissure point. Where is the pars triangularis? Where is the pars orbicularis? And where is the ventral premotor cortex? So the combination of ventral premotor cortex, pars triangularis, and the pars orbicularis indicate the language production center, means Broca's area. So that area is critical for language for output, so should be preserved well. Of course, we should know where is the inferior frontal sulcus, where is the superior frontal sulcus, where is the meeting point of inferior frontal sulcus and the precentral sulcus, where is the meeting point of the superior frontal sulcus and precentral sulcus. That's mean the hand notch, mean the hand area for movement. So after being familiar with the anatomical landmark, we can perform a personalized operation. Of course, the medial aspect of the cortex should also be familiar with our young generation neurosurgeon. For example, for this case, we should understand where is the mesial part of the superior frontal gyrus and where is the cingulate gyrus. And this is the anterior cingulate gyrus close to the middle cingulate gyrus. And here is the pregenual, subgenual. And here is the rectus, and here is the pole of the cingulate gyrus, and here is the periolfactory, periterminal gyrus. So for frontal lobectomy, all of this area will be safe to resected. And we also should inspect where is the system of the corpus callosum. This is the bottom view of our frontal lobe. We can resect the frontal lobe until the margin of the olfactory triangle. That means the posterior parts of the olfactory triangle is the anterior perforated substance. That means the lenticular striatal artery will originate from the MCA, M1 part, and vertically into the basal ganglia. So we can resect the frontal lobe until the triangle. After learning the landmark of the frontal lobe, we can perform a perfect frontal lobectomy, preserve the central core, the new basal ganglia, and preserve the supplementary motor cortex. So the posterior margin will be detected by using the subcortical mapping. We preserve the motor cortex as well as the subcortical motor fiber. And the frontal lobe will be resected gross totally. This is the mesial view of the frontal lobe resection. You can see we resect the mesial part of superior frontal gyrus, the cingulate gyrus, until the system of the corpus callosum, and preserve the anterior perforated substance. So now I'd like to show a video. So this is a video about the right side frontal lobe resection. So this is a female young neuroscientist. So he agreed to perform a weak craniotomy, and during tumor resection, we perform brain mappings. This is the mini shave of the female patient, and after craniotomy, we will perform cortical mapping before tumor resection, and to find where is the motor area, where is the language related area. So after that, we can resect the contrast component first, gross totally resect the abnormal component on the image. And then we perform a lobectomy. We resect the remain frontal lobe tissue. On the bottom view, we trace the olfactory tract until the triangle and preserve the anterior perforated substance. And the mesial aspect, we can detect where is the system of the corpus callosum, preserve the body of the corpus callosum, genu of the corpus callosum, the minor forceps originate from the corpus callosum, and we can resect the anterior parts of the supplementary motor cortex and preserve the bridging vein. And the lateral side, we preserve the short gyri of insula. So here you can see the anterior limiting circus, superior limiting circus, and after that, we achieve a gross resection of frontal lobe. And this is the imaging during intraoperative MRI imaging. You can see there is still some tumor remnants on T2 FLAIR image located in the minor forceps. So we continues tumor resection. And after that, the MRI imaging, it confirmed the lobectomy of the frontal lobe. And we closed the wound. And several weeks after operation, we performed the regular neurophysiological evaluation. You can see the patient with less impairment of his cognitive function as well as the language function. So this is a very typical case for frontal, right side frontal lobectomy. We gross total resected the frontal lobe. For left side, we can preserve the inferior frontal gyrus to protect the language output center. For example, the pars triangularis, pars orbicularis, as well as the ventral part of prefrontal cortex. So this is two cases of frontal lobectomy. Let's talk about the temporal lobectomy. So this is the lateral view of our cortex. And here is the frontal, here is the occipital temporal notch. And here is the parietal occipital sulcus, also named the parietal occipital fissure. So we can make a connection line. So before is the temporal lobe and this inferior parietal lobe, and behind is the occipital lobe. And this is the lateral side of our cortex. This is the bottom view of our cortex. Here you can see the collateral sulcus, fusiform gyrus, occipital temporal sulcus. And here is the pretemporal gyrus, anterior temporal area, and here is the uncus, and beneath is the amygdala, and here is the parahippocampal gyrus, and here is the isthmus of the cingulate gyrus, and here is the lingual gyrus. So for temporal lobectomy, sometimes we should preserve the mesotemporal structure, including the amygdala, including the hippocampal gyrus, as well as the subiculum. This is the mesial aspect of the temporal lobe. Here you can see the uncus. Here you can see the head of the hippocampus and the dentate gyrus, the fimbriae, and the connected to the phonics. So all the mesotemporal structure will be preserved for the dominant side temporal lobectomy. So this is a surgical rehearsal on the specimen. So I always use this picture to train my young neurosurgeon to train the residents. So for the dominant side, we will preserve the transverse temporal gyrus. The first transverse temporal gyrus is the facial gyrus, meaning the auditory cortex that should be preserved. And the posterior components of the the superior temporal gyrus is the Wernicke area. That means the language comprehension critical area. So should be preserved, especially for the dominant side. This is the mesial aspect of the temporal lobectomy. So here I'd like to also show a video chip about the temporal glioma resection by using a temporal lobectomy technology. So this is a malignant glioblastoma. Intraoperative molecular evaluation is IDH wild type TERT mutant. So we decide to preserve a right side temporal lobectomy. So for this case, mini temporal approach will be used. It is enough to expose the temporal lobe. So after exposing of the lesion, first of all, I will resect the contrasting component of the tumor. During the tumor resection will be some bleeding. We can control the bleeding by using the normal technology. And after that, we will perform anatomical lobectomy. So our plan is resect the uncus, resect the amygdala, and preserve the hippocampus, as well as the subiculum for this case. So this is the image after lobectomy. Here you can see this is the hippocampus. It is well preserved, and here is the choroidal fissure. So above is the basal ganglia that should be preserved well. Otherwise, the patient will suffer from hemiplegia. This is the image during operation, intraoperative MRI scan image. After conformation of standard right side temporal lobectomy, we stop operation. And this is the 3D reconstruction of the cortex. It is similar to the specimen rehearsal, surgical rehearsal. And this is image 3 days after operation. You can see this is a very perfect anterior or temporal lobectomy. It's very useful for our malignant glioma cases. So I'd like to show some other cases of lobectomy. So this is a complete temporal lobectomy for right side glioma, glioblastoma cases. So here you can see the posterior margin is very close to the occipital-temporal notch. That means the border of temporal lobe and the occipital lobe. And for this case, totally we have two contrasting enhancing components. So this is a very malignant cases. So our surgical plan for this case is combine the temporal lobectomy and occipital lobectomy. So for this case, we perform a total resect of the temporal lobe as well as the occipital lobe. So this is the MR image T1 contrast imaging after operation in 3 days. So you can see the resection margin is perfect in accordance with the pre-surgical plan. So how about the parietal lobectomy? So this is the up view of our cortex. We should identify where is the meeting point of the intraparietal sulcus and the posterior central sulcus, and where is the posterior central lobe, and where is the parietal occipital fissure. That means the margin between the parietal lobe and the occipital lobe. So we keep in mind the landmark of anatomy. So after that, we can go step into the surgical operating theater. So this is the mesial view of our cortex. Here you can see the cingulate sulcus, and here is the marginal sulcus, and here is very deep fissure. This fissure is the parietal occipital fissure. So forward is the parietal superior parietal lobule.
પછી ક્યારે આપવાના ક્યારે એને
અઠવાડિયામાં આવશે આજે 22 છે.
I'm sorry, go ahead.
Okay, can I go ahead?
Yes,
Okay.
please.
We should resect the parietal lobe until the system of the corpus callosum. Here is the splenium of the corpus callosum, and we will resect the retrosplenium, and the isthmus of the cingulate gyrus. So this is a surgical rehearsal on a specimen. So you can see after the parietal lobectomy, sometimes the atrium of the ventricle will exposed to us. So this is a typical case. So before operation, you can see on the T1 contrast image, there is a malignant glioma lesion located in the parietal lobule. So our surgical plan is to do a parietal lobectomy for this case. And the anterior margin is the marginal sulcus. The posterior border of the tumor resection is the parietal occipital sulcus. And the deep margin is until the splenium of the corpus callosum and the major fossa. So this is the image several days after operation. So you can see we perform a perfect tumor resection, perfect lobectomy for this case. So we have followed up this case for more than 2 years, still progression-free survival. So finally, we will talk about occipital lobectomy. Of course, the occipital lobectomy, after occipital lobectomy, the patient will suffer from the visual field loss. But for malignant cases, I think it's worse. So this is the mesial aspect of our cortex. Here you can see the parietal occipital fissure, very deep fissure until the isthmus of the cingulate gyrus. And beneath is the lingual gyrus. Lingual gyrus is the mesial part of the inferior occipital lobule. And here you can see the Cacrine fissure. So above and beneath the Cacrine fissure is the primary optical cortex. So after operation, the person will suffer from the visual field loss. This is a surgical rehearsal on the specimen. So after tumor resection, the occipital horn of the lateral ventricle were exposed to the surgeon. So now we preserve the video chip. So this is a case of malignant tumor lesion located in the occipital. I'd like to show the MR imaging. And here you can see this is a 3D reconstruction of the Miles loop, the optic radiation, 3D reconstruction of the pyramidal tract. And this is the visual activation on both image, functional MR imaging. So we perform, our plan is to perform occipital lobectomy. So prone position will be used for this case. And after that, during operation, we perform the fluorescent sodium guidance. And first of all, we will resect the contrast enhancing component by using the fluorescent sodium guidance. So after the contrast enhancing component resection, we step going on to resect the occipital lobe. So after occipital lobe resection, here is the Wernicke area, the posterior part of the superior temporal gyrus. It will be preserved because this is a left side, that means a dominant side glioma. So we should preserve the posterior part of the Wernicke's area. And after occipital lobectomy, you can see the atrium of the lateral ventricle, and you can see the sylvian fissure. You can see the posterior part of the hippocampus. Here is the hippocampus. This is the body of the hippocampus and the atrium of the lateral ventricle. And here you can see the choroidal fissure around the posterior part of the thalamus. And this is the image after operation. So this is also a perfect occipital lobectomy for this case. This is the intraoperative imaging of this case. So totally, we have performed more than 30 cases of lobectomy, tumor resection. So now our proposal is to initiate a clinical trial, a prospective multi-center randomized clinical trial to compare the routine gross total resection of contrast enhancement and the lobectomy is the surgical technique. So our proposal is to see the overall survival of the cases will be prolonged significantly. So if anyone have interest to involve in this prospective multicenter randomized control trial, it will be welcomed. You can contact with us by using the email address. This email address belongs to one of my research fellow. He will collect the information and contact to you. Thank you so much to have the opportunity. It's my privilege to give a talk here today. And if you have any question, will be welcomed. Thank you. Stop. OK。正好一个课，昨天我给他们讲是3个。我现在倾向于就是在确保安全的情况下，这个越大越好。
Wow. Okay, I believe we're waiting to go to the OR. Okay. Can you hear me? Oh.
Hello, John. This is Bing.
Hey, Ben, how you doing?
Hi. Fine. Yeah.
Thank you very much for presenting. But you're getting a lot.
Any questions for Professor Wu Jingsong?
Well, are you broadcasting this to Brain Med?
Oh, actually, Marcos told me this just before the lecture, so I don't have time to.
Yeah. Okay. No. I'll send a WeChat to them and tell them.
Yeah. But okay. But for tomorrow we can arrange. Yes.
Okay.
Okay.
Have you had churrasco yet?
Mm-hmm.
Have you had churrasco yet?
Okay.
And maybe someone can describe what we're going to see. Are you there, Marco? Maybe you're probably setting up. I believe Dr. Schiefler. Hello. Okay. Right. I believe he's setting up. That is Diego, who's setting up the technical part from Brazil. Because when you have this kind of a setup, you've got to ensure that the viewer sees something. You just don't want to see the surgeon standing over the wound. You want to see obviously inside the wound. I'm sure they'll have a microscope camera or possibly endoscope.
Hello, John. Do you hear me?
Yes.
Nice. John,
Yes.
we're just finishing the setup here at the surgical room, and Max Wagner is here. Dr. Max Wagner is already here, and I'm going to pass for him in a few minutes. Just
Okay,
wait for us.
You'll be commenting, right?
Yeah, he will be commenting.
Okay.
Okay, so just a few minutes, because we are waiting for the professors that were at the auditorium to get here.
Could you please present the patient in a brief paragraph, just shortly?
I'm gonna ask Dr. Max Wagner to do that. Okay.
Okay.
Just a minute.
Okay. All right. Okay. Yeah, we need the microphone. That's a little detail.
Ok. A máscara,
Greetings.
para pegar a máscara. Podemos.
Okay, Marco.
Olá, pessoal. Estamos aqui no nosso segundo dia, né, de trabalho, e hoje nós teremos uma cirurgia aqui de neuralgia do trigêmeo, a fossa posterior. É um paciente com dor incapacitante, né, um senhor de 60 anos, e a gente vai fazer uma cirurgia assessorada pelo professor Kai Michel, mas nós iremos fazer a cirurgia, o brasileiro. E aqui nós estamos com o doutor Luciano Holanda, né, que é o coordenador, o chefe do serviço de neurocirurgia do Hospital Antônio Tagino. vai falar um pouco da experiência desses dias, de como é que está a situação aqui, desses casos. Recebemos o maior número de visitantes aqui, né, da cidade, pessoas de universidades bem representativas no mundo. Então, doutor Luciano, sua experiência hoje, o que é que está achando disso aí?
Bom dia, eu acho que o serviço do Hospital Antônio Tagino e o CNNRH, é o Centro de Neurologia e Neurocirurgia, Rafael Holanda, sempre inovando em trazer o que há de melhor no mundo. Estamos trazendo vários neurocirurgiões internacionais para nos abrilhantar, trazendo novas experiências e, com isso, também ele adquirir nossas experiências. Nós temos um serviço longo, um serviço há muito tempo de referência no Nordeste. Muito obrigado a todos e sejam bem-vindos.
Thank you, Marco. Could you translate that into
Okay,
English for our
and now we
English
have
speaking?
here Professor Jin-Sung Woo from Fudan, great lecturer. Thank you for your patience and kindness for giving this lecture and be with us here again with us. And here we have a posterior fossa case. It's a trigeminal neuralgia. It's a excruciating pain, and it's a live surgery. Professor Kai Schoffler will do. What the experience of coming here by CNS, Asian Congress of Neurological Surgery, to share expertise with other countries, and especially here, the Northeast region of Brazil is a region that is still underdeveloping. And with these collaborations, we are happy to have you. So give your experiences and highlighting.
Thank you so much for having me. I think it's my privilege to be here, to be invited to involve in this operation. So I'm earnest to learn some surgical technique from the senior professor. And every time we go abroad for international observation, I will learn some technique from the colleagues. So today I will be very interested in learning from your side. Thank you so much.
And what is your daily work in China? What you do primarily in your work day?
So actually, I'm a neuro-oncological surgeon. So my routine work is glioma surgery. Annually, my personal experience is above 500 cases. So I focus on the brain tumor surgery. Of course, not all of the cases are glioma surgery, but also some, for example, pituitary, sometimes will be some skull-base or prostate, something like that.
You do some posterior fossa
Yeah, but
surgeries?
very few cases.
Very few cases. Okay, thank you. Professor Binshu, can you come here? How are your expectations, what you're seeing, your happiness, say message for your Asian friends?
Yeah, I think Asian neurosurgeon may have more communications with Americans neurosurgeons, including Latin Americans neurosurgeons. And we have a lot of common aspects. We are both developing countries, and in some remote province, the basic facility was not so good, and we can learn each other. Yeah.
Thank you, Professor. So take your seat. And I can
Yeah,
translate.
Ben,
To have the researchers to be giving support to us. As you know, we are from
can you get Ben back for a second? Is he still there?
Yeah, he's still there. I will translate Professor Luciano, and then I will give you in touch.
Okay. Okay.
So Luciano told to you in Portuguese that he's really happy to have you making connections,
Okay.
collaborations with all the neurosurgical societies in the world. So it's a great pleasure for you. You are part of it to make us together with Professor Jin-Sung Woo, Professor Kai Schoffler, that he wished to do a project like this with you, also from connecting German, China, and other countries. So it's a great worldwide networking, and I think that's going to be a great step for new future activities. Okay,
Yeah.
and Professor Shu, Professor Shu, John Bennett want to talk with you.
Okay.
Yeah, Ben, can you hear
Hello,
me
John.
okay?
Hi. Yes, yes.
Yeah, we do appreciate all the collaboration you've done with us so far.
Mhm.
You really seem to try to be trying to open the door, and we want to help you. We want to help you. We'd love to put together Chinese conferences, for example. I would like to invite Dr. Jinsong to head a conference on the latest research in gliomas in
Yeah,
China.
yes.
We could learn a lot from that. And thank you very much.
Thank you, John. Thank you for actually you supplied with a very open platform for us. Thank you.
You're welcome.
Mhm.
And now we're gonna to the case promptly. Here we have Professor Schäufler. Can you explain the case using images? Can you show the images here? We basically have this MRI, and it shows maybe some conflicts here from the
Daniel, how you doing?
artery here in conflict with the nerve. But I was discussing with the professor, maybe sometimes this case of trigeminal neuralgia is not important to have a true image. It's just the exploration of the region
Yeah.
and see what you can find there and separate it.
I don't know if I
Please.
did that yesterday or not.
Shut up, please, shut up. No parallel conversation, please. And so the image here sometimes doesn't show exactly, but they have an excruciating pain from the patient and he's refractory for all kinds of
Emmanuel, I'm in the
treatments.
middle of a webcast.
So
Could I call you back? Or I'll send
So
it.
now, John,
I'll
please.
send it, okay?
Shut up.
Okay, thank you, John. I will wait for you.
I'll talk to you later.
Okay.
Can I continue? Shut up, please. Silence. So sometimes it's not important to have a true image lesion conflicting showing something like that. So we just need to do the surgery and the patient is refractory to regular medicine. So here we have Professor Schäufler from Germany, from Asklepios Clinic Zessen. And now he's the second day of live surgery. Now he's going to explain what's his philosophy in treating posterior fossa lesions in trigeminal neuralgia cases. So.
Thank you. Good morning. So this is a quite straightforward case of trigeminal neuralgia on the right side. We have a neurovascular conflict shown left side. Left side. We have it shown on the MRI, but it's not important. The MRI is basically done to exclude tumors or other lesions that could lead to secondary trigeminal neuralgia. But this is a primary case with a supposed neurovascular conflict. So we're going to do a straightforward microvascular decompression, potentially of the superior cerebellar artery, but we will see during exploration of the posterior fossa. Okay, we'll just go ahead. Okay. Okay. Yes. Let me start. That's the occipital artery. So no occipital artery bypass today.
No.
We've just killed it.
Yes, maybe.
Yeah, this is certainly the one.
But I'm
certainly.
not sure they have the instruments.
No. And some sort of respiratory. And here. One. Maybe, do you have a bigger one? Yeah. That's also too small. That one. Yeah. Yes. Oh, yes. Okay. Very good. Yes. All righty. Okay, so then we can take the trephine to do the hole. Yeah, this one, yeah.
Does it have the bigger with the heterogeneous?
Oh, yeah. I don't know how good this works. If this is strong enough, we can take this one. Let's try. And here, and some water. Irrigation, yes. I think it's not good enough. Now let's open the other one. Ah. Okay. So, Yeah, take this one. No, I can still take this one more time. We have a dissector. No, smaller. You have and to use this one, but okay. Then we okay, yes, got better. And then we can take the rose and the rose burr. Yeah, yeah. Yes. Yes. Yep. Thank you. This guy. It's not good. Yeah. In this case, with these instruments, I do a craniectomy. So, no offense, but
no, okay.
but
if you can craniotomy.
yes, of course, yeah. And also, I guess we don't have. Do you know what tachocele is? Some sort of where you just put it on the dura, on the sinus, if you have a sinus laceration. So I don't have all of this. So no way I'm doing craniotomy here. Absolutely no way. Hi, John. Can you hear me?
Hi, can I talk?
Yes, I can. Thank you,
Here
Marcos.
we have our daily neurosurgical procedure. It's a public patient that we operate here in the private hospital. It's a good thing for a patient to be in this environment. That's our setup of neurosurgery. You see that sometimes we don't have high quality equipment, but we have tried to do the best with the minimal conditions that we have for working. So we can do many cases, but in Brazil, we are fighting for equity to have a good resource, a good setup for operating patients. It doesn't matter it is from the public or from the private sector. Here we have this division. We have a private sector which has much funding, but the public sector for a private hospital is difficult to deal with because the funding is not so enough and sufficient to have a good environment for neurosurgery. But we are trying to work with the resources which we have and try to do the best.
Yeah, can I ask you a question,
Almost
Marcos?
now.
Oh, I can't. Too late. I missed my chance.
Meu Diego, tira o
Can you hear me, Marcos? That's okay. I'll wait. I'll wait.
Mocinha, aspirador para mim. Here we're doing a craniectomy because we have a problem with power drills. But our aim objective is to relieve the pain of the patient, and you see craniectomy is also a technique.
And we have some big plongeurs, like
Sure.
yeah, it works. I'll just
Okay.
Okay.
Thank you.
Not this.
You do sometimes craniectomy? You do sometimes in German craniectomy?
I never do.
Never.
Never.
But we can try to do a palacus here
Yes,
afterwards,
yes,
and
of course, of course, of course.
we can make a
Yeah, we can do a
repairment.
bypass.
So no
Yeah.
problem.
Yes. But I don't, if I have a problem, if I'm getting a problem with the sinus here, under these conditions, I don't know. No. The I think it's this one here. Yes. Yeah.
A true German one.
Okay. Yes. Yes. This is from a little bit big. You can try.
Yeah.
Oh, is it?
Yeah, it's steered. Can I talk with John? John there or not?
Sure. Can you explain the original procedure,
Can
Marcos?
you on the microphone of the professor?
Oh, okay. Yeah.
Okay.
That
Wilson tá
unfortunately,
contigo? E do
yeah,
professor, tá falando?
yeah,
You can talk to us about how is your experience in working in a department different from yours.
Yeah. Of
I know
course,
it's a different experience.
It's a different experience. You have to adapt to many things that are completely different to what you're used to. And that's in an operative environment is a very significant challenge, of course. So we need to adapt a lot and also change strategies and adapt strategies and yeah, it's exciting, but it's a true challenge.
Naturally, for us, as we are more accustomed with, it's not a problem because we have the capacity of being.
Yes.
It's as I'm a president of the Northeast Society of Neurosurgery. Now we are going to our capital. That's what we are fighting for.
Yeah.
To bring equity in neurosurgery. You know, we have to have high. We don't want a starship to go to Mars. We just want a simple instrument from good companies that can afford us and make us cooperate in a really comfortable setup.
Yeah, it's not just about being comfortable, it's also about being safe. Because if you're doing surgery on the posterior fossa, you have to be ready for some, like in this case, it could be a large venous emissary, and that can at times be quite tedious to treat. So you need to be prepared for that and adapt your whole strategy to that. If you're using instruments that you're not used to using, it's different.
Yes. So we are happy to have you to be adapted to all of this challenge. I know it's not difficult, but it shows that you are really prepared for everything.
Yes, must be prepared for everything. Yes,
even for a lion or for a rabbit.
Yes, exactly. Yes, right.
And when you're back home, you're going to be greater because if you operate in this field,
exactly.
you can do many others. And we are not masking our reality. That's what we are using in daily activities.
Yes.
As I told you, it's a private hospital that has public patients, so the funding is difficult for them to provide, of course, high-end neurosurgical instruments.
Is it a big problem getting permission from the patient or the hospital? Is there a big legal thing like there would be in the United States?
It's good because
no,
maybe people on Congress show.
This is it. This is the deal. Yeah, this is it.
Yeah.
No blinders. This is it.
Everyone has problems in your department. You have already, yeah, problems of daily. Where is the confluence of the sinus? It's right there. Yeah, it's enough for you.
It should be enough.
Yes,
should be enough. Okay, so then we can switch to the microscope.
Can you explain the phases there in with the camera?
Yes.
Can you talk to them?
Yes, there. Okay.
Diego, you're gonna make a take.
Okay, so we've just finished our craniectomy, upper posterior fossa on the left side, and now we're going to do the dural opening. dissecting over the surface of the cerebellum to the ambient cistern, going to release some CSF to gain a lot of working space, pull down the cerebellum just a little bit to expose the cerebellum pontine angle, and then go straight to the trigeminal nerve.
Thank you.
What difficulties if you can find in this approach there? What kind of difficulties?
Well, the difficulties can be, of course, the worst one is a very big sinus with large venous emissaries, so you can have a lot of bleeding during the exposure already. That's one of the biggest difficulties. Some patients, especially elderly patients, have a very, very thin dura. So in some cases, you don't even find a good plane between the bone and the dura. And then you have the problem of dural closure at the end of the operation. So that can be unique challenges to this kind of surgery in elderly patients.
Uh, okay, I believe we're setting up. Hello, are you there, Marco? We're kind of losing you there on the camera. Hmm.
Okay, John, we are just preparing here to put the microscope, so that's why we are offline. So
Okay.
it will take more 1 minute just to prepare
Okay.
here the surgical unit for the microscope to get in, okay? So take
Okay.
it easy.
Just,
As
just
soon as
let,
possible, we're gonna get again
okay,
online.
just let us know.
What music? Hear me? John, can you hear me?
Yes, I can hear you.
We just take off the images because it's microscope to get in, so take care, okay?
Okay.
Stage movements. Are you enjoying, John? This kind of transmission is our true reality, you know. Here, as I told before, we are in a private hospital, but this patient is public. We have some
Okay.
problems of equipment. It's a problem of Brazil neurosurgery. It has a different levels of assistance. If you go to other hospitals, you have good machines and equipment. You have here, even in my hospital, if you have a private patient, you can have all resources. But sometimes for public patients, the resources are minimal, but we can do all the objectives that we aim. Okay?
Yeah, we'll talk later about the minimum amount of equipment that
Okay.
a decent, we'll talk about that later.
Yeah.
But we'll,
But I want just to illustrate to our colleagues, you know.
okay.
Spatulas are the spatulas.
We just now open the dura mater. Right the system.
Okay, we're not seeing the camera. We're not really.
Okay. Diego, please open the camera now. So he uses this kind of
Okay, there we go.
Leica Yashakil spatula system. It saves you time in neurosurgical procedures. You know, some surgeons don't use it, go direct to the systems and release CSF, but some others use it. Oh, tá aqui. Tá. Just made one.
All right. So working now. Yes. But it takes a little force, but it's good. All right. So now then.
Brazilians have a hard hands. So let me see here before. Excuse me, Professor.
Now we can also take a smaller suction. I'm going to change my gloves.
Você number 6.
That's great.
Our team today is not so because our friend is on shift.
Yes. That's okay.
So here the limit is to expose the transverse sinus. It's a safety landmark that we use for the limit of our craniotomy. Não vai. Diego, tá para ligar uma luzinha só, tá muito escuro.
Here, so I'm going to wax those right away because I don't want to
CSF leaks.
CSF leak. Some remnants.
Enough to avoid CSF leak, yeah?
Yes. So then it's absolutely vital to expose the transverse sinus. We see right here. Okay. All right. Now we take a
Where is the
little
marker
knife,
sectors?
15 knife, and
This one is
small forceps, small surgical forceps.
I had already did that.
Maybe this one here.
That one?
I hope this one's working. Oh no, it's too big. Yes, that's too big. But this is anatomic. This is an anatomic forceps. I need a surgical.
You can take the
Oh no, this is also anatomic.
Dá problema aí, por favor, mocinho.
Excellent camera.
Ah, back here. Okay. Now he's opening the dura mater in a perfect symmetry. And now he's trying to pushing the dura to open the space to release CSF leaks. You can leave it. It's okay. Lucinha, liga só foco para não ficar tão escuro aqui. I need a micro forceps. No, the micro forceps. So long pointed. You choose. Yesterday, I can use this one maybe. Okay, and then patties, cotton. Eu uso algodão, mocinho. Aqueles algodãozinho. Wait a moment. Ótimo. Do we have smaller ones than these? Mm-hmm. Smaller in size or in smaller in size or in extension? Yes. Smaller size. Okay. Okay, now we're releasing CSF from the ambient cistern. Can you explain this anatomy, Professor? Yes. So this is the upper edge of the cerebellopontine angle. You can see here the facial nerve. And prepared, maybe you can conclude these with a trigeminal nerve. Yes, but it's always superficial. So if you know that the facial nerve bundle
is so superficial, it's basically impossible to mistake this for the trigeminal nerve, which lies a lot more ventrally. But of course, if you lack the experience, then you can mistake this for the trigeminal nerve. Okay, now I need this thing here. This, and
Do
now we
you,
put in the
do you sense for glioma, ICG, and so on? A bit.
Okay, can you close the spatula, please? No? Right. All right. And what's
like to use this part?
what's the light? How much light do we have?
Almost 100%.
Almost 100%. Okay.
Maximum.
Okay. Whoa, 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 whoa.
Sorry. I'll
Oh.
reduce this suction.
Okay. So here comes the trigeminal nerve.
That's the conflict.
That is probably the conflict right here. And also,
This vessel, can you coagulate it? No problem with this, but
no, I would never. This one here, the petrosal vein can be coagulated. It doesn't need to be in most cases, but you can coagulate it. Yes. Me too. I don't have a good.
Você reduz a aspiração? Tá muito forte. I reduce the suction.
Make the suction a little bit less aggressive. Reduce the suction.
I reduced.
Okay. Okay. Micro scissor. Yes. Oh. I hope this is very short. No, that's much too short. We need a bayonet.
It's
Yes,
a
that
little
one.
bit big.
Yes. Yeah. Yeah. We see. It's very big, but that's the only one we had yesterday as well. So better than nothing. Okay. So then take this one again. Or can you release that one? It's very dangerous. Yeah, we can. If we can reduce the suction a little more, that would be very good.
Reduz mais a aspiração, reduzir mais.
Okay, so it seems that here, right here,
A loop.
this is a loop. And this is causing the conflict. So we're going to separate this. We can already take some.
You can use this as a test one.
Let me separate here. Okay. Isso aqui é o Teflon, né, Ron? This one.
Não, não é isso aí não.
E cadê o Teflon?
É o soldador. Só quando eu boto um... Esse é o da... Vira aqui pra eu ver. Tem que ser menos 5, cara.
Peça ela lá.
Como assim?
We're gonna take the Teflon. Yes. You're gonna take the Teflon. Yes. Can you explore more the anatomy from the trigeminal nerve to illustrate? Primeiro que aparece é o facial. Can you explain to us the posterior fossa anatomy? Yeah, so here we have a very good overview. We can start at the top. So right here we see the tentorium, under surface of the tentorium. This is the trochlear nerve with the superior cerebellar artery right here. What? Those are usually vessels that create neurovascular conflicts with the trigeminal nerve, are the two trunks of the superior cerebellar artery. This being the upper trunk and this being the lower trunk right here, but they don't have any obvious contact with the trigeminal nerve. We're going to look at those two, but it doesn't seem they have contact in the vicinity of the trigeminal nerve entry zone into the brainstem. So this vessel right here certainly doesn't seem to be the problem, but rather this one here, and this is the ICA. So we're going to separate the arachnoid right here, fully exposing the trigeminal nerve, and then placing some Teflon film.
The arachnoid became thick.
No, I think this is a very regular anatomy, aside from the vascular contact right here, which of course is not a massive one. So the nerve is slightly, as you can see here, there's a slight indentation on the nerve. So the nerve is compressed by the vessel. But the most important thing is that you have the pulsation of the artery directly on the trigeminal nerve all the time, especially here at the trigeminal nerve entry zone. So the most important part is going to be to separate right here below the vein. Not here. This is probably not the problem, but the problem is right here.
So the important site is
the important site is the entry zone of the trigeminal nerve. It's not the peripheral portion, but the right here.
Mm-hmm. So it's a beautiful case.
Yeah, it's a very classic case.
So in every case of trigeminal neuralgia, you have to do an exploration of the posterior fossa.
Absolutely.
Sometimes you don't find nothing.
Yeah, sometimes you just find a vein that's right here within the trigeminal nerve. And then I will just coagulate the vein. And this will also do the job in most of the cases, actually. So it doesn't have to be an arterial compression, it can also be a venous conflict. So one needs to be aware of that possibility too. It's very important. It's not just arteries that can cause problems, but also veins. And this spatula sits a little bit tight. Okay, do we have, I need the micro scissors one more time. These ones, yeah.
Some surgeons make some manipulations of the nerve like this.
Yes, yeah. Well, as it works, the spatula is not really ideal because it's, yeah, now it's much better. The manipulation of the nerve, you always have some manipulation of the nerve as soon as you open the arachnoid. but I think it's not the major. The major action really is the vascular decompression.
The anatomical.
Yeah, the anatomic
separation.
decompression. Yeah. Yeah. So I guess we need to dissect this region a little more. Right here. Unfortunately, a little bit obstructed by the retractor, but right here, right there.
So what is your opinion about those peripheral treatments like balloon?
This is definitely second choice or third choice. If you can avoid it, you should definitely avoid it, because the chance of getting completely rid of the pain is a lot lower. So the percentage of successful treatment with any peripheral treatment is just around 60%. If you're working on the Gasserian ganglion, if you're working more peripheral, it's even worse. And if you're working directly here at the nerve entry zone, it's above 90%. So that's a huge difference. And I would never voluntarily offer a patient a second tier treatment.
Are higher because it's not that effective.
Yeah, but if you have to treat, to treat the patients with medication all the time, the cost is definitely higher. Can we reduce the suction a little bit?
Mocinha,
Is that possible?
reduzir a aspiração, mocinha? Mocinha.
Oh, it's right here. Okay, got it. No, oh no, let's just
Let's make a start. Have to do it wet.
very, very difficult. Because I will need some suction.
Let me watch.
Just take the vein. Okay, what's the intensity of the
Bipolar?
bipolar oil?
40 maximum.
Yeah, I want 7, please.
7. What I said aí? Bipolar em 7. 7. Okay.
No, 7.
7.
Not 37. 7.
It was in 7. Okay.
Yes. Okay. All right.
That's what I said.
Okay. Oh, please don't. Just leave it. It's very dangerous if you.
So, Diego, o microfone tá ligado? So, at the end, you have to coagulate the veins.
I want to coagulate the vein because I want to expose this very proximal part of the artery crossing the nerve right here. This is the objective. It's no use if you just release this part here, but you also have to release this part here. That's very important. And I want to coagulate this little vein, no problem. Okay, now. Not good. I need smaller parts. That's a big. Like this.
Want plastic glue?
Yeah, we can.
Afterwards?
Yeah. We need to put some glue. Please. The suction, we need to reduce the suction. It's
Pode,
extremely
mocinha,
dangerous.
pode tirar a sucção, mano. It is kind of Teflon. It's a Teflon.
It's a Teflon?
Yes, you can use it for the... Okay. Praticamente será, mocinha. Yeah, but now we're going to use the Teflon.
Yeah. Okay.
Yeah. You can use the finger here from the control.
Yeah.
It's a Teflon for separating the arterial punch.
I just wonder why it is no longer mobile.
Tá começando, não?
Não sei. Deixa eu voltar para lá. Daí de lá você pode conversar com ele, entendeu? Vai ouvi-lo.
Very good. John? John, hi, John. Hi, John. So we use in this Teflon component to make a true separation between the nerve and the artery. So it's the best way for us to have a good result. And this region, the entry zone of the nerve, the most strategic region for you to make the separations.
Okay, so now we can put
Effective.
some. Now we can put some glue, and then
Okay.
it's good.
Color biological. Now we're gonna set glue, because sometimes you have a failure of this procedure. Can fall and the conflict comes again. So you have the bio glue to have almost 100 of active treatment. So the objective is already done. Mission almost accomplished. Now at the other room in the ICU, in DSA unit, we're gonna have Professor Binshu making an DSA for a patient with a suspicion of fusiform aneurysm. Hi, John. Can you hear me?
Yes, I can hear you.
Any doubts, any questions from the audience? I'm open. And Professor Schäufler also is
Okay, let me post that right now.
for any questions. And
Okay, I'll let you know. Sean, do you have any questions? I don't know if Sean.
Black, Preta.
Marco, are you busy?
No, I'm okay. I'm here. The BioGlue, that will be the final step because
Yeah,
we have to fix the Teflon in his place because if not, it can fail and have a recurrence. It's excruciating pain, John. You cannot even imagine how the patient was suffering.
Okay.
And fortunately, we can provide this treatment for him. It's a really curative patients, but we need to have some some care afterwards. We can keep his treatments of medications, of pills, and gradually we can reduce the pills. You cannot stay off immediately after the surgery. We keep him with the drugs, but afterwards we can safely remove all the drugs and can say that we can cure him. Okay, it's a curative neurosurgical procedure. Can you tell us about the history of the surgery? Who was the beginning has made this? Do you know, Professor?
Well, the surgery initially was coined by Peter Tanetta in the 60s. And he observed the contact of vessels with the trigeminal nerve in the posterior fossa in patients with trigeminal neuralgia. And started to mobilize the vessels from the nerves, keep them distant from the nerve, and had immediate success. With his first patients, we continued doing it primarily by observation, and since then it really has become a mainstay of treatment of trigeminal neuralgia. Although I have to say that there are huge differences in different countries, and is by no means a standard treatment in many countries. So We had patients coming from other countries, even from inner European countries like Switzerland, where there was no treatment for trigeminal neuralgia, no surgical treatment, just medical treatment. And of course, these patients really have suffered for a long time. And we're really happy to receive some treatment in the end. We have a longer syringe to apply the glue.
Uma agulha de hack mais grossa.
And many patients will not tolerate microvascular decompression because they're too old. This, in my experience, is a pure myth because I've virtually never experienced a patient who was too old or too sick to undergo this procedure. So this is really something that those physicians who treat trigeminal neuralgia have to get used to, is to offer this opportunity for their patients because it's much more effective than any other treatment today.
What kind of treatment do you have in your department?
Well,
As
we
an
offer patients
alternative.
primarily microvascular decompression, and as a second-line therapy, which is rarely used now, the sweep procedure, so the thermocoagulation of the posterior ganglion. No peripheral treatment, because I think it's completely outdated, it should not be done. And of course, medical treatment, but most of these patients come because medical treatment is no longer working or has never really worked for them. And that's quite a significant portion of these patients where medical treatment really never has led to a sufficient reduction in pain. And those patients should not wait for a Janetta procedure for a decade. I mean, this is just not, should not be the way of treating these patients.
And
this
you
is actually
operate
what has happened.
Recurrence patients with the
Very rarely we have
MVD?
recurrences, and even for most patients, we offer surgical revision. And if we find a vascular contact, we will alleviate the vascular contact. If we don't find it, we will offer the patient a selective rhizotomy. So that means we'll cut a part of the trigeminal, of the sensory trigeminal root, and that will also lead to excellent effects, and by no means to a complete anesthesia of the part of the face that is treated. So this is also something that surgeons need to be aware of. The shorter one, please.
And what you
Dr.
find
Yes.
Hi.
Dr. Marcos here.
I can hear you.
So it's Diego. I'm here with Dr. Binchu. We are at the DSA room, just waiting for the patient.
Okay, thank you. So, is Dr. Hommel with you?
Not yet.
Okay, so tell the nurses to do it.
Yeah, we are here. We are waiting for the patient. Maybe he's coming also.
Okay.
With the
Maybe
patient.
we can have an interval of broadcasting after finish here. It's up to you, okay? You can manage that.
Okay, when we start here, then I talk to you.
Okay.
Just a general question, Marcos. I'm not a neurosurgeon, but I see there's a lot of equipment there. Is there much problem with maintenance? Do they frequently break down, or are they pretty self-sustaining?
Repair of what? Can you speak slowly, please?
Did you hear me?
Yeah, I can hear you.
Yeah. Do these machines break down a lot?
Yes, we need to have a lot of machines.
What
They
do
keep maintenance. Yes, we have it. Yeah. We use a power drill, which is from the Brazilian industry. This one, it works good because for us to get imported ones, it has great taxes. It's a way for us to empower our local industry. But each equipment here, they need to have
the small.
We need to have
do we have a smaller
maintenance. Can I take
Right. And
Yes.
the maintenance comes from the company that made the machine?
Yes, yes. We have preventive maintenance,
Okay,
you know. Mostly of the instruments that we use here, they are from Brazilian companies.
okay. Now,
And
is
it's
something,
getting better day by day. They are trying to improve the quality, you know.
how quick are they with repairs?
It's to the company and then it's easy. No problem. Not a problem to fix. Can you hear me?
Yes,
You have to tight this. Can you hear me, John?
yes.
Ele tá me ouvindo, Diego?
Sim, estamos lhe ouvindo. We can hear you.
So this time of the surgery, you have to take care. As you go direct to the disease, you have to know how to back home. If you leave any empty space between the dura mater, you can have a CSF leaks. But we neurosurgeons know how to deal with it. It's not a problem. Also, we can use external lumbar drainage. We can do it. Microscope is good, they focus.
Tá muito bom o foco, a gente consegue ver tudo perfeitamente.
You see that Professor Kai Schoeffler, it's a challenging for him to be here to operate in the different environment. But it's important also for him to have this experience, and he will gonna back home with other impressions about neurosurgery in different places. We don't have the setup which they have there in Europe and in most of the European departments, but we can do many things quality of assistance here for neurosurgical departments. I think all colleagues have problems in each department, but we try to do the best with minimum weapons. But it's changing. This kind of exchange program supported by Neurosurgical TV is good because it are bridges for long distance departments. The past is almost possible for us to have this kind of exchange. The internet make us in one word. So it's a watertight closure. Sorry, I cut it. BioGlue, it's a great weapon in neurosurgery. It helps a lot. We have here public patients. Você pega ali. I will reinforce with bio glue to close all the spaces.
No.
It's important. Glue. Done?
Yeah, it's not working anymore.
Yeah. One touch put it with the bone. No,
I think that's
enough.
no good. Yeah. I think rather Palakos.
okay.
And this piece of bone is not going to do any good.
Is it okay?
Yes.
Finish?
Yes.
Okay. Now we're gonna closure the other plans, and surgery almost done. So we're gonna finish now. Can you go there and resume what you do? And I close here.
Yes.
Okay. Go there in the camera. Ele vai aí para dar uma geral do caso. Hã?
I didn't catch what that signal meant. Point up to the ceiling. I think he meant, Marco meant the lights, right? The overhead camera.
John, can you see me?
Yes.
So we are here with Dr. Bin Chu also, and we are waiting for the patient to come here to the SA room. Doctor, do you already know about the patient, about the case?
I'm not sure. They just take it.
Okay, so we are waiting for the patient, and then maybe Dr. Romulo can explain more. Maybe we could take a break. I don't know. I think the patient's coming. It's arriving now. Maybe we can use, you know, a screensaver for a while. Is it possible?
Well, yeah, could we go over the patient's history, why he came to the hospital, and what kind of studies were done, et cetera. And could we do that now? Or
Yeah, we are just waiting, Dr. Homu, and he's coming to explain this.
oh, okay. Just to give the audience a good idea of what you guys are doing.
For sure, for sure. Just a minute, then we can back.
Okay.
The incision layer by layer, because it helps also to have a good result. If you don't close, we can have a risk of CSF leaks. And that's what we are doing now. It's almost closed. Now we're gonna do the skin level, skin. One on item. Please. Perfectly close. Here's the incision most proximal to the mastoid region. I like to close it. All plans to make a good recovery of the incision.
Dr. Kai, we are still on the room with the audience.
Yes.
I would like you to comment what the situation of the patient, what are the expectations after the surgery.
Right. So that was a very clear-cut case, so very regular case where you have a clear neurovascular contact and arterial contact, and I would estimate that the patient would be pain-free immediately after the surgery. And we could really fix Teflon belt very
Separated stitches.
I hope that's going to be a lasting
I'll
for
close
us.
it continuous in a continuous shape.
That's good.
Much
Dr. Marcus,
faster,
do you still hear us? Do you hear
more
us?
hemostatic.
I don't think so.
Ok. Ok. Pode tirar o microfone, viu? E apagar.
Dr. Marcos, você nos escuta? Dr. Marcos, você nos escuta?
Escuto.
We are here with Dr. Carl, and Dr. Bichu, and waiting just the patient be prepared. Your microphone is on if you want to comment something.
Here, okay. I'm always finishing the incision. I like to do continuous incision because much more than patient goes to the ICU and it's okay. So no bleeding, the incision is safe, no kind of problem. That's all. Can you take a camera of the surgical unit for us to take all the... Diego, can you close everything? Now just talk. Now.
Yeah, sure. No problem.
Can you see me in the camera?
Yeah, yeah.
So everybody, I really glad to have you here in this audience for this morning. And now we're gonna take a break. We're gonna now prepare the patient for the DSA unit to have issue.
So it'll be Binshu
No?
live,
Okay.
live, right?
Binchu live, yes. Okay, Binchu
Okay,
live, just performing GSA.
In
a
about
angiography.
15, did you say 15 to 20 minutes? Because I want to
Yes,
announce it.
almost that. After
wanna
that,
announce it.
we will announce the
Yeah, I
right
wanna-
moment for
I
you to
wanna
get online.
announce- Yeah, I want to announce that Ben is speaking. Okay, great.
Okay. Thank you, John.
I'll see you in a few minutes.
Okay, thank you. Tirou as câmeras todas?
Oh,
Hi, John. We are here.
yes.
We're just waiting for the exams. And then Dr. Marcos will explain the case, and then we start the procedure.
Okay. Okay.
5 minutes, maybe.
Okay,
Or-
Marco is going to introduce the piece.
Yes, he's going
Okay.
to do it.
Okay, thank you. Um,
This case is
John, we are
Yes.
back. We're ready to explain the case when
Okay, hold
when
on.
you call
Okay,
on your call.
it's a
okay, hold on.
Hold on.
Give me a second. Okay, here we go. Okay, returning back to the conference in Brazil. And here's Marco to continue from the DSA room.
Yes. Here, hi, John. Happy to have you with you again. Now it's the second case for today. It's just a diagnostic procedure, a DSA diagnostic. We don't intend to treat her, but it's a patient of 44 years old, a female patient that has some tinnitus in the left ear. And before she had done an exam, it was about a fusiform aneurysm. We have examined her previous examinations. We don't see nothing at all. So that's why Professor Shu is here with our Brazilian support team to have deep examinations and see how is her arterial images. Okay, so let's go on.
Okay, I guess, do we have any access to any studies, Marco, like the CT or the MRI or anything like that? Do you have those handy, or it's too difficult to retrieve?
I'll make you a history of the patient based on images. Just
Yeah,
wait a
okay,
moment.
okay.
Thank you.
So, John, in Portuguese, we call this kind of procedure hemodinâmica.
Okay.
It would be in English something as hemodynamics, hemodynamics maybe. And the patients are already here, and we have the doctors in this room, and they were just waiting for the exams, and they're all here. And with the anesthesiologist, Doutora Tamara. She's here already. What about our signal, John? It's good. Video and audio.
Yes, it's good.
Okay, great.
Yeah, can we go over the image? Can we go over the images now? Ben, can you go over the image, please?
John is asking you to explain about the images that we have.
Just this is my first time I'm looking for.
Okay.
I'm not sure about here. It looks like a very stenosis part. I'm not sure. Yeah. This is the only
What all patient already with?
suspected segment. Because the ECA branches were all good. Normally tinnitus come from some dural AVF. Yeah, but it looks good.
Almost normal.
I think it's almost normal. There's no AVF here, and then no AVM.
It's 40. She's 40.
She's 44.
Oh, 44.
So I'm not sure about this segment. You know,
Let me show this segment here.
Maybe some problem. Yeah.
Stenosis.
Yes, it's very looks like severe stenosis.
And can give these symptoms of it.
Yeah. Maybe.
What is your impression about a case like this, Professor Schoenfeld? This one here. We're talking about this one. Yes.
Do you receive these patients in your daily practice?
Yes, of course. We have those patients which, well, many of them come with some sort of tinnitus, where the ENT specialist didn't find anything, no problem with the inner ear. So that's quite regular that we have to evaluate those patients, and we do that together with our radiologists and the neurologists. And of course, the majority of them receives conventional angiography for evaluation, and then we have a neurovascular conference where we discuss these imagery together. Yeah, that happens every week. Yeah, very usual.
Yes, and actually, this angiogram, they didn't show the vein face. Sometimes the stenosis of the vein also can cause tinnitus.
Yes.
Yeah. Especially the sigmoid, the transverse segment of the sinus.
Yes.
Sometimes we don't make it arteriography for some tinnitus, and we lose many diseases of vascular etiology.
Yes.
There is a Brazilian man who support you, okay? He's experienced in all these diseases.
So you mean I'm going to do the angiogram?
Yes.
Okay. Okay.
Feel free. Good luck. Time.
I'm thinking that after they did the angiogram, we find the disease and we treat it.
No treatment today, just for diagnostic.
Okay.
Afterwards, you go to an oncological hospital to visit the department there. Very much listen.
So what we have now in okay, so I think I won't be able to be inside, and I'm just leave the camera here, and we can comment as if you want. Let me see that. John, as we have a situation with X-ray inside, so we won't be able to put equipment inside because of the radiation, and we're going to stay with the camera and the microphone outside, and as the procedure was going on, then we can comment from here. For now, we're just going to watch and wait for the procedure start, and then we can comment here with Dr. Marcus Wagner and Dr. Session. Okay? So I'm going to find a good place to leave the camera here, and then I go back to you.
Okay.
Por favor. Aquele porta-caneta, por favor. Eu acho que eu consigo botar aqui em cima. Obrigado. So while the X-ray is not on yet, I'm gonna show it closer. Enquanto o raio-x não estiver ativo, eu posso ficar por aqui, né? E podem me dizer se eu estiver atrapalhando alguma coisa. Posso passar por aqui do lado. Não, tranquilo, eu vou pro outro lado, vou pro outro lado. Eu ali vou ficar de frente, cara.
Actually, we never use natural sound, but Alfred is quite good, but
Me dá Chile. Parece que foi.
So the access to the catheter was done right now successfully.
Yeah, could you explain what he's doing now, Marco?
Just a minute.
Okay.
Who is speaking is Diego. Marco is outside. He got the access for the catheter. We thought it was necessary the ultrasound, but wasn't. So we're going to start the procedure now.
Okay.
Da área terminal na parte médica.
Yeah, Marco, what procedure was that?
Marco is not here yet. He's coming back. I'm going to explain you just a minute.
Okay.
It's Diego is speaking.
Okay.
So the puncture was done successfully. He got the access to the arteria, and then we're going to use the catheter to get the veins you want to see using the X-ray, and the patient cannot be sedated completely because of he needs to be collaborative, because the situation is she's hearing some noise in the left ear, so they need to see if the noise stops or.
Okay.
It's
It's not a roller, it's a kick plate.
Hã?
Acho que agora vai ser o momento que ele vai usar o raio.
Então, é onde a gente vai.
Quer colocar o capô? Bota lá. Ele é tranquilo, né, velho?
Então, segura aqui para eu organizar. Alguém pode segurar para mim? So are you going to start using the X-ray? And I'll be back soon.
Zoom. Eu posso mexer o braço assim, tá? Está.
Ok, tudo bem.
Uhum. E quando terminar, ele vai discutir isso.
Muito obrigado.
John, will make an interval now for making the exam, and then afterwards we can discuss the image results. Okay, thank you.
John, did you hear?
No. Could you repeat, please?
Marcus, repeat, please.
We're gonna make an interval, a stop. After the exam, we can discuss what he found.
Oh,
Okay.
Okay.
On interval. Thank you. Take a break. We're gonna make a break.
Okay.
Then I'm gonna leave the meeting because of the battery. We are using a mobile device, and then we go back.
Okay.
So we'll be right back. When we finish, then Professor will discuss the case and what he found.
Okay.
We'll be back in a few minutes.
Okay.
So John, we are back. Are you still there?
Yes.
Just finishing.
Yes.
Let's get back on your call, John.
Now we,
Professor, just a minute.
Okay, we're gonna have the procedure explained.
Yes.
Okay, we're ready.
So, Professor,
Hello,
please
John.
explain what.
Today we repeat the angiogram for the patient again. So we did the 3 arteries angiogram, both sides CCA, including the ICA and the ECA totally. So there's no totally normal, and there's nothing, no aneurysm, no stenosis, everything is good. But on the venous side, you can see the right side and the left side transverse sinus was not even. So the main blood drain from the brain drain to the left side.
If I get closer.
Okay. From mainly drain to the left side. So the right side transverse sinus was very small, and then almost all the drain, the blood flow of the brain come to the left side. And we can see on the MRI, this is a cochlea, and the vein was here. So you can see the vein just very close to the cochlea. So the blood flow in the vein can be heard by the patient. So that's the cause. So there's no PAVF, no everything. So the patient don't need to treat. Yeah.
And
so for those who was planning to do some procedure there,
yeah, it's okay. Because you know, in different angle, the stenosis is okay. Just because the vein was just too close to the cochlea. So the cochlea can hear the voice of the blood flow. That's
maybe some inner ear.
Yes, yes.
It can mismatch. It
yes,
can...
yes. Because the vein is too wide.
There is a kind of in-ear equivalent.
Yes, inner cochlea.
Inner cochlea.
Just beside the vein.
Because it's...
Yeah.
So
the train blood flow in the vein can be heard by the patient.
Okay, let's gonna close everyone here. Okay. Professor here, Professor Gilson. Can you come here for to make the closure? So we are here on 4, and we're glad for the ACNS and the German Neurosurgical Society for coming here. Those are happy and again glad to have you here, so everyone can speak.
All right. Thanks very much for having me, for having us. A great pleasure. And very interesting to see how things work around this part of the world.
Yeah, thank you. I think it's both a happy day for us and for the patients, because there's no disease for the patients. That's great.
Just anatomical variables.
Yes, yes, yes.
Okay, very
So
good.
as I this interactive training course, I always learn a lot. Thank you so much.
Okay.
Okay,
Yes.
I'd like to thank everyone for their efforts, and maybe we'll see you tomorrow. Is something going on tomorrow?
I'm gonna try to make casting from the Congress. I would let you know on Thursday.
Okay, just let us know. Okay, thank you, everybody.